Good afternoon, we can hear you clearly.
I'm not seeing where I can project now my computers, my presentations. Just assist me.
Let me see about that. Nelson, you can be able to, yeah, you are now a co-host. You're now a co-host, you can be able to share.
So it is red, just share screen.
Yes, at the share screen button.
Button.
Yes, the green one, yeah, share screen button, then you can be able to share your presentation.
Sour. I try to open
it. Maybe you can press on the yes, on that button.
I can now start.
Yes, you can now start with introducing yourself, and you can go into the presentation. Karibu sana.
Yeah, thank you so much. Good afternoon for everyone. Today we are just looking about the chronic kidney disease in children. It's just a little information in the introductions. It's not all the details because it's chronic kidney disease is a complex disease, and we have a lot of information to know and to learn. However, I try to summarize it, at least we can have the common understanding, how we can make the diagnosis, and how we can follow up at least the children whom we meet in our clinic. So these are my learning objectives today. So we look about the definitions, etiology, epidemiology, clinical manifestations, and the management of chronic kidney disease. The chronic kidney disease in children is a public health concern. Some causes may start in utero. For example, what we call the congenital anomaly of the kidney and urinary tract infection. Urinary tract. One of the examples, for example, posterior valve reflux, polycystic kidney disease. Those are the diseases which are appearing in the utero. And despite advanced the modality for renal replacement therapy, chronic kidney disease in children remain disappointing. So, despite now the modality for the dialysis, like the continuous renal replacement therapy, the thread dialysis, so the chronic kidney disease in children is disappointing. So, because one, there's a delayed diagnosis. Secondly, it is a chronic disease which requires the parent to be available, to be patient. Sometimes it requires a lot of money from the parent they don't have. So it is one of the complex disease. Chronic kidney disease is a major risk factor for mortality and morbidity in children. As we look at far and forward, for example, the children with the chronic kidney disease, they increase the hypertension, proteinuria, coronary artery disease, stroke, chronic infections, blood loss, anemia, all those are the complications which increase now their mortality and morbidities. What is the definition of the chronic kidney disease? So chronic kidney disease is defined as reversible functional of structures with the kidney damage, which is more than 3 months. So now this definitions, this first one is not applicable for the children less than 3 months because now that for the children you can't apply. So either it can be supported by pathological abnormality, which you can find either by kidney biopsy or either by imaging, where you found now the kidney size are really shrunken, you compare with the normal size, or that you can get for the blood sample abnormality, where the children has anemia, has hypocalcemia, has hyperphosphatemia, creatinine elevated urea, especially in the abnormality of the blood gas analysis. Or either it could be urine abnormality, where the children will have now the proteinuria, especially microproteinuria. So, and now when you consider the EGFR, also you consider EGFR less than 60 mL per minute per min, 1/73 meters square, more than 1 month. So, however, now this definition, the last one for the EGFR, is not applied for the children also below 2 years because their average GFR is almost there. So we support to combine now those clinical features in the laboratory to confirm the diagnosis. So we can do now staging of the chronic kidney disease. So we have a kidney disease outcome quality initiative and the kidney disease improve global outcome. So they have almost the similar classification. So stage 1 is the child who has eGFR above 90 or equal at 90. Stage 2 is in a KDC1 is when you have a GFR between 60 and 85, which is the and 89, which is the same. So you found now the difference is stage 3, because in the KDIGO, which is more commonly used in the pediatric, you have stage 3A and stage 3B. Stage 3A is GFR 45 to 59, stage 3B 30 to 44, and then stage 4, where you have now 15 to 29, and the stage 5 less than 15. So you may find now the difference either in this other category also they consider now to have the dialysis. However, when you consider now to calculate the GFR, if you remember for the last presentation that we did for AKI, the way you can estimate the glomerular filtration rate, you take the constant at 40 times the height of the patient in centimeter, then divide by creatinine. So this is the modified Schwartz formulas. So this one we used when they use what we call the enzymatic method in the laboratory for analysis of the creatinine levels. So I think this one, the people, they can just look later in definition. This one is showing, for example, now average estimated the GFR according to the age of the children. So as you can see, for example, for the first 3 days of life, eGFR is between 14 to plus or minus 5. When you come, for example, that's the preterm, or different for the term baby, 20, 0.8 minus or plus 5. And when you have, for example, at 2 years, 1 to 2 years can be now GFR 105 plus or minus 17. So these are the people they can look about later, and they can just have to look at when they, especially the clinician, when they want to estimate the GFR for the children. How burden of the chronic kidney disease? So little information about the children concerning the epidemiology of chronic kidney disease. Reason is because there is late diagnosis and there's confusion to make the diagnosis of the chronic kidney disease. So where we need to have high index of suspicions. However, the study was reported by the Lancet last year. In 2017, 697 million were CKD. That's include all age, including the children and the adult. So the global prevalence of the chronic kidney disease in whole populations was estimated to be 9.1. And when you consider now this prevalence of the AKI has been increased from 1990 to 29.3%. So you can see how the chronic kidney disease and other non-communicable diseases are increasing. So in 2017, there are 35 million on dialysis. And the 2017, 1.2 million people died from chronic kidney disease. So, and when you see, for example, now the global age mortality, chronic mortality of CKD increased now 41.5 from 19 to 2017. You can see how the burden of the chronic kidney disease in the whole populations. So, as I said, there is little unknown about the prevalence of the chronic kidney disease in children. However, some countries, they have some studies. For example, in Italy, the prevalence of the chronic kidney disease was 74.7 children per million. France, 7.5 children per million. And in Japan, 3 to 5 children per million. So what is now the risk factors for chronic kidney disease in the children? So one is preterm birth. So when you consider preterm birth and the small gestational age, medical term IGR, it's because the children who are born premature or who are born with the lower birth weight, they have a reduced number of nephron. So when they reduce the number of the nephron, as long as the child is increasing in age, the small number of the nephron, they increase now the the work. So you have hyperfiltration, you will have now the hypertrophy of the glomeruli, you can have a kidney leakage of the protein, you have proteinuria, and later along the remaining nephron, you have hypertension and the other complications. Also, there is familial history of the genetic kidney disease, that is increased risk factors. Also, there is history of the acute kidney injury and the congenital anomaly of the kidneys and urinary as I said. So also if the child has vesical irritable reflux, especially high grade from stage 4, stage 5, that is high risk to develop now the chronic kidney disease. And now any abnormality of the chronic kidney disease, it's worsening any abnormality of the kidney in the urethra, it's increasing the probability of the chronic kidney disease. In which way? Because the children with the anomaly of the kidneys, they have high risk to get chronic and recurrent urinary tract infections. Once the children has urinary tract infection, there is scarring. When there is scarring, so they reduce the number of the nephron, and those remaining number of the nephron, they increase now the hyperfiltration, which includes the high risk of the chronic kidney disease and later on. So there is a history of some diseases like acute nephritis, nephrotic syndrome, especially when you consider steroid resistance nephrotic syndromes, membranous nephropathy, membranoproliferative. So some systemic disease like henoch-purpura, hemolytic uremic syndrome, the children with hypertension, the diabetes, obesities, systemic and autoimmune disease like the rheumatoid arthritis, sickle cell anemia, when you have them, sickle cell trait, and also for the children who has spina bifida or neurogenic bladder, those are in other risk factors. So also for the children with the Brown-Berry syndrome, so they have a high risk to get nowadays the risk factor of the chronic kidney disease. So when we consider now the most common condition associated with the chronic kidney disease in children, the most common is what we call the acute congenital anomaly of the kidney and urinary tract, because account more than 60% of the children with chronic kidney disease. So that's including the cyst, including now the multicystic dysplastic kidney disease, is including congenital hydronephrosis, it's including posterior valve reflux disease. So all those congenital anomalies, they increase the chronic kidney disease. So you can have the glomerular disease, nephrotic syndrome, nephrotic syndrome, acute glomerulonephritis, pyelonephritis, all the disease they increase nowadays, the chronic kidney disease later alone. So systemic disease, as I said, systemic lupus erythematosus, diabetes mellitus, hypertension, and kidney tumors. So also other etiology for, especially for the youngest ladies, is the tumor which affect now the ovaries. Usually the tumor which affect the ovaries also associated now the chronic kidney disease in the children. So what is the clinical manifestation of the chronic kidney disease? So at the earlier stage, stage 1 to stage 3, there's usually no any specific sign. So maybe what you can find clinically, the child may have maybe sign of the underlying condition. Maybe the child has recurrent urinary tract infections. Maybe the child who is not eating well, has a nausea, abdominal pain, a child who is not gaining weight. So, but there's no any specific sign apart if now the progression was very worse. So maybe some sign of the chronic kidney disease, you can see according to the progression, as I say. So if the child come at the stage 4, stage 5, is where most of the children we got in our clinic. However, some children who has posterior valve reflux or other obstructive uropathy, we're able to detect the area because we have a joint team with the pediatric surgeon. So those one you can detect the area, especially for the first 2 years of their life. So systemic examination, maybe if child is underweight, has fear to thrive, you can find maybe hematological, you can find the anemia. If you do now with the blood, your blood, you can anemia usually chronic kidney disease, normocytic, normochromic anemia. So in GRT symptom, you can have nausea and the poor appetite. Usually those are signs associated with the uremia. So you can have a metabolic sign, like for example, rickets, uremic symptoms. Uremia it's coming for most of the abnormality. Usually the anemia will cause now the metabolic acidosis, will cause now the pericarditis, will cause the epidemic encephalopathy. It will depends how the severity of the uremia is. So also you found the electrolyte imbalance, which is the most common and the first diagnosis for the chronic kidney disease. For electrolyte imbalance, we found now elevated the urea, elevated creatinine. You found the metabolic acidosis. Usually it's high on the gap metabolic acidosis in the IKI, but it's almost normal metabolic acidosis in the chronic kidney disease because there's that chronic compensation. So you may find also the hyperkalemia most of the times. Maybe you may find now cardiovascular system abnormality like hypertension, or maybe the child will come with the fluid overload. However, the children usually are not taking the blood pressure in most of the facilities. We need to have a high index of suspicion. For the child who come with sign of the rickets, who come with now nausea, poor appetite, they fail to gain weight, the child who complaining of the headache and the blood divisions. So may you check the blood pressure and you estimate how the blood pressure for that child is. It's better to do now the creatinine levels and you estimate now GFR using that modified Schwartz formula to know how the severity of the AKI is. So now we are going to manage now the chronic kidney disease. The chronic kidney disease, it's a long journey to manage. So chronic kidney disease require multidisciplinary teams. It requires nutritionists, it requires the counselor, it requires the surgeon, it requires urologists, nephrologists, so pediatrician, the nurses support. It is just a whole team also including the publics and the families. So what we supposed to know first, there's now 4 principles or 4 goals for treating chronic kidney disease. One is treat reversible kidney disease, slow progression of the end-stage renal disease, to manage the complication, and to prepare for renal replacement therapy. We can look one by one. So to treat now the reversible conditions, so for the reversible condition, we support to avoid the nephrotoxic drugs, like anesthesia, amyloglycoside, radiocontrast nephropathy. For example, the children, if the chemo wants to give, for example, the drug which affected the kidney, like cyclophosphamide, you remember to hydrate, you remember to give a methina to reduce the risk of the progressions. We support to treat and to prevent dehydration, especially for children who has now acute gastroenteritis. And if possible, you treat obstructive uropathy. That's where we could now the surgery. You can fix the catheter, you can do urinary deviation by cystostomy, you can do ureterostomy. So there's so many modalities according to what we can find by cystoscopy and what you can find through the electration stoichiogram as investigations. Hello? Okay, so the second one, it will be now slow progression to end-stage renal disease. So the chronic kidney disease progression, it has at least this graph, the simple graph to remember. One is hyperfiltrations. Hyperfiltration, it comes where you have now this number of the kidney, the number of the nephrons. The remaining one will overtake the lost. So that's where you have now hyperfiltrations. Hyperfiltration will now associate with the glomerulopathy and the glomerulosclerosis. And that one will give the proteinuria, which will continue to worsening now the kidneys by podocyte injuries. So proteinuria also will cause now the inflammatory cells. As chronic kidney disease is an inflammatory disease. So now, as long as now you have hyperfiltration, you have proteinuria, so you have a reduced number of the nephrons. That's why it's rising now the hypertension. So once you have hypertension, now, so you reduce now you reduce now the blood is supplying to the kidneys because you increase now those vasoconstrictions. So it's when you have a lot of problems. So, and there is many issues here called the renin-angiotensin system. If you remember now, renin-angiotensin system, we have a renin produced by juxtaglomerular apparatus of the kidneys, which now we join now angiotensin 1 in the cardiac muscles, in the lungs, in the kidney, in the blood vessels. So then angiotensin 2 angiotensin converters to give now angiotensin 2, which is stimulatory vasoconstrictions. So once you have now vasoconstrictions, we increase now the blood pressure, reduce the kidney supply, which is cycles. So however, angiotensin 2 also has non-hemodynamic conditions where it will now, it is a proliferative, it includes now proliferation of apoptosis. It will recruit a cytokine like nicotinosin factor, alpha, interleukin 1, so chemokines, and that one is worsen glomerulofiltrations. And in terms of the, and on the cortex, the renin-angiotensin 2, it will promote now endothelial remodeling in endothelial cell injury. So which one will increase and worsen the chronic kidney disease? Here now, our management as the nephrology, we try to give the drug which usually are working on renin-angiotensin aldosterone systems. It's where all the children with CKD stage 1 to stage 4, you can give now ACE inhibitors, or you can give ARBs now to contract now the action of the renin-angiotensins. So at the same time, so they prevent proteinuria, also to reduce the pro-inflammatory, reduce podocyte injury, and reduce now hyperfiltration. So in this case, renin-angiotensin system is supposed to be blocked by ACE inhibitors and the ARBs. So now you go for treating the complications. So the complications of the chronic kidney disease are so many, but I try to highlight the most common complications. So one is anemia, bone mineral disorder, growth failure, hypertension, and the metabolic acidosis. When you look at, for example, now the chronic kidney disease in the anemia, if you look at now these pictures, you found, for example, in chronic kidney disease stage 1, here you found how anemia it's one of the most complications of the chronic kidney disease. So you see, for example, you look at now how it's increasing. It's come from almost around 25 at stage 1, and then you have anemia at around almost 100% at stage 4, 5, when the children are under hemodialysis. However, as you found the other, so you see the acidosis here, which is increasing in the worsening by times. You have salt wasting, you have now hyperkalemia, which also is increasing, also the bone mineral disease and the growth failure. So you found the children, more the chronic kidney disease stage increase, more the complication now worsening. So anemia is a common complication of the chronic kidney disease, as you observed the previous figures. Is associated with several complications, including the death, hospitalization, and the development and the progression of the cardiovascular risk, a factor such as left ventricular hypertrophy, and also the anemia, so and also hypertension. So when you have now hypertension which is not treated, see there is now overworking of the heart, which try to satisfy the metabolic needs. So there is stretch of the muscles, there is left ventricular hypertrophy. So there is increase in the worsening of hypertension. So there's decrease now in the glomerular filtration, there's decreasing glomerular blood supply. So that will increase the glomerular filtration rate, worsening the injuries, and at the end of the time, it is not corrected the ways. Without now affecting the growth failure, so it's affecting now the renal system, what you call it now the anemia, which can cause cardiorenal anemia syndromes. So the prevalence of anemia increases with stage. That one is so for the previous. I think we found now for that previous stage. So you can see now the stage 6, 73%, at stage 5, 87%. So, and for the children at stage 5 is more than 93% of prevalence for anemia. So these figures is the same with the one we saw. However, this one is just trying to summarizing only for the anemia and the hematocrit. What we can find now is how the progression of the chronic kidney disease and the worsening of the anemia. So now we can see how now anemia is happening in chronic kidney disease. So you will have first the many factors for anemia in chronic kidney is erythropoietin deficiency, and this is called the hypoxia-induced factors alpha, which supports stimulate now the kidney to produce now the red blood cells. So as long as the number of the nephron are reduced, as long as also the erythropoietin also is reduced, and it's the one which supports stimulating now the kidney and the bone marrow to produce the red blood cells. So another problem with anemia, which is called anemia, it's where you have now the iron, folate, vitamin B12 deficiency, and the carotene deficiency. Usually, those deficiencies you look why. First, the restrictions, because most of the food are restrictions in chronic kidney disease. The secondary cause is also the uremia, which causes nausea, vomiting, and poor appetite. So you may have the blood loss. You have the blood loss through the hemodialysis or through a lot of venous sampling. So you have the chronic inflammation when you have what called the molecular called hepcidin. So hepcidin, which produced in the liver, it's increasing when now there is chronic kidney disease. And once now there is hepcidin, which is supposed now to reduce now the sensitivity of the kidney to produce now the red blood cells. So you have now those complications. So also the uremia can suppress bone marrow, can cause now the thrombocytopenia, which increasing also will worsening for the reducing the red blood lifespan. Also, once you have uremia in the bone marrow suppression, you are not longer producing now the red blood cells. So WHO and with them kidney disease improvement global outcome has classified the anemia when you have the normal hemoglobin level according to the age and the gender, which is lower than 2 standard deviations as the norm. So this is at least the table. I think you can look about it later. But when you consider anemia in chronic kidney disease, so you consider these figures according to the age of the children. So which laboratory investigation you can do? Some of them you can get it very easier. So we do complete blood count. You see now how's the hemoglobin level and the MCV. So you can do absolute reticulocyte count to know if now you have the bone marrow suppression or not. You do ferritin levels, you do serum transferrin saturations, and serum vitamin B12 and the folate levels to know where we are. So now, what is now the treatment? So for the treatment of anemia, there are so multiple approaches. So one, you can give either oral or IV iron. So IV iron use the Venofer, the most commonly used. All children with CKD not on erythropoietin stimulating agent, not on erythropoietin or the protein. Oral iron or IV is recommended when transferrin saturation is less than 20 and the ferritin level is less than 100 nanograms. So we support to have now those levels to know where we started and if you are increasing, if you are improving or not improving. So pediatric chronic kidney disease, patient on erythropoietin stimulating agent therapy who are not receiving iron supplementation or IV. So we are not using when they have transferrin saturation above 420% and the ferritin level above 4,100 grams. One, it's because now you increase the hemosiderosis and the complications. So you have now erythropoietin stimulating agent, which is a cornerstone in management of anemia in chronic kidney disease. So the benefits reduce now the number of the blood transfusions. You promote also the growth So the complication though, therapeutic stimulating agent, the most documented is stroke, vascular access loss, and hypertension. Usually for most of the children with the therapeutic stimulating agent, they have the stenosis of the blood vessels. For us, we found when we are analyzing the children, we found now we have all the access. So also they have the stroke, also the thrombosis. That's the complications. So we suppose now to monitor the hemoglobin level before and after starting now erythropoietins. Usually we monitor the after 1 month. So if now there is no improvement between from the baseline at 0.3 gram per deciliter, so you are supposed to check the adherence, to check other comorbidity, or is supposed to do, for example, the solo card, to do colonoscopy, to do upper GIT study if there's no other blood loss. Then if you found now adherence, the compliance are okay, but you are unable to increase the hemoglobin at 0.3, it's better to stop it participating agent because it's non-sensitive. So the blood transfusion, it's controversial in chronic kidney disease. So because it is associated with increasing now the risk of the rejection after renal transplantations. However, you're supposed to weigh the benefit of it and the complications. We remember this complication which is the graft rejection. So you can have infection like HIV, even if the risk is very low. So you can get malaria, you can get other disease. So always you check the patient, you assess the risk, and you assess the benefit. One indication of the blood transfusion in chronic kidney disease is symptom of anemia. So the child who has anemia, who has tachycardia, who has palpitation, who has difficulty in breathing, not associated with uremia, this is an indication of the blood transfusions. So sometimes you may check also the primary disease. If the child has hemoglobinopathy, like for example, sickle cell disease associated with chronic kidney disease, those one you can start to transfuse hemoglobin is at certain levels, at least for 6 or 7, if there is no other complication. So we give also the blood when you have bone marrow failure, when you do reticulocyte count found it is still normal or lower, or when you assess now the patient after starting erythropoietin stimulating agent and you found there is resistance. Or if you have now anemia with complications or contraindications of the erythropoietin stimulating agent. That's why you have, if you have, for example, so the malignancy or the stroke, so that time you can't give now the erythropoietin supplement agent, you support to give now the blood transfusion. So also you support to combine your treatment with vitamin C, vitamin D, vitamin E, folic acid, and the L-carnitines. So when sometimes you may have patient who need treatment of anemia as the agent, which is the reason and which is indication. It's when rapid correction of the anemia is required to stabilize the patient's conditions. Example, acute hemorrhage, maybe catheter insertions and the hemorrhage. And subcoronary artery disease, when you have a rapid pre-operative and you support to correct the hemoglobin levels. So another treatment is just hypertension. As all of us we know, especially in adult, hypertension is increasing the risk of mortality, morbidity in children with CKD. So, and is increasing according to the nowadays CKD stages. So in our target in the treatment of hypertension is to slow blood pressure slowly, initially at below 90 percentiles, but our target is supposed to be at 50 percentile for the blood pressure. So that one for other doctors is supposed to have now the curve. There's a curve and the table for the blood pressure of the children according to the age and according to the weight. No, according to the gender, not the weight. So, however, what I can highlight for all the audience, the blood pressure in the children, the simple way you can assess at least historic blood pressure is the age of the child times 3, plus 100. So if any blood, if the blood pressure which has a certain level, it's meaning you have now 95th percentile, you need to treat. So the AC inhibitors and the ARBs are recommended for initially because they saw the progression of the chronic kidney disease, but they are contraindicated when you are in stage 5. Or when you have severe hyperkalemia, which are not resolved with the medical management, you're supposed to choose another drugs. So you may still have an alternative drug like beta blocker, carvedilol, atenolol, propranolol, a diuretic like lasix, metozolol, the vasodilator like hydralazine, minoxidil, calcium channels blocker like amlodipine. So you still have so many drugs you can use. Also, you have the diet and lifestyle modification to reduce the blood pressure. That you have now to do exercise when it is possible, reduce the fluid intake and the salt intake. So we come now for the bone and mineral disorder and chronic kidney disease. So as a definition, we have two spectra. CKD-MBD bone disorder is a full spectrum of mineral and the endocrine disorder. You have now hypocalcemia, hyperphosphatemia, hyperparathyroidism. So, and the low vitamin D3. But renal cell dystrophy, we are talking about impact of the disease on skeletal systems. So the bone mineral disorder are affecting the cardiovascular systems because they associate the vascular calcifications. The clinical symptoms usually start at stage 3 of chronic kidney disease, and of course, they worsen the progression of the chronic kidney disease. So what you can see, maybe skeletal deformities, fractures, muscular and the bone pain, not the bonus, and the bone pains, avascular necrosis for the femurs, and the growth failure, which is the most common. So how, for example, we can define now the chronic renal failure will affect now the impaired excretion of the net acid in the urea. It affects impaired formation of the active metabolite of vitamin D and impaired excretion of phosphate. That's the phosphate. So all those, they are interacting together. So now, for example, if you have now uremia, it will affect the muscle in the pain because it degrades now the uremia will cause the insulin resistance, and you don't have a good nutrition. So it affects the mitochondria. So what happened? So it affects now the skeletal parathyroid hormone resistance. So at the same time, when you have raised now phosphate, so if you have now once you have now a lower phosphate, you are not digesting, no, you are not absorbing the calcium in the gut. When you are not absorbing the calcium in the gut, so you have now bone resorptions, where you try now to compensate the calcium in extravascular compartment. So now once you have a lower calcium and the higher phosphate, so the stimulation now of the parathyroid hormone, which overtake the actions. However, because you are unable now to create now the minerals, you will have also secondary hyperparathyroidism. So now the clinical manifestation for you can have renal cell dystrophy, where you have now the bone in the muscle, or you can have secondary hyperparathyroidism, as I said, and all of those, they will precipitate the advent injury. So how we can do investigation? You can do blood samples, you can do imaging, but you can do serum calcium phosphate, magnesium, vitamin D, PTH, and the alkaline phosphatase, and you see how it look like. You can do X-ray for the hip, X-ray for the upper and the lower limb, especially the joint and the wrist. Then for the management, you can create a calcium, either you can give the oral or IV, so can give calcium gluconate. In case there's a now hypocalcemic tetany, or can give all supplementations. So can also give vitamin D, either IV, no IM, either weekly or monthly, it depends on the severity. Also can give now vitamin D as oral. And if in case of hyperphosphatemia, you can now bind phosphate either by actotams and sevelamer. So actotams, we even have hyperphosphatemia, and you have hypocalcemia. Several will give when you have hyperphosphatemia and the normal calcium levels. So growth failure, so the growth failure in children with chronic kidney, it's the most common seen sign when you can see for the children. So it's defined by height for age below 30 percentile. So impaired growth is a complication of the chronic kidney disease where it is manifested by short stages. And the growth failure increases progression of the chronic kidney disease, and it's increasing the mortality at 14%. So now what is the cause? So the cause of the growth failure in the short statures in the bone mineral disorder and the chronic kidney disease. One, it's malnutrition. So malnutrition is caused by either you have now the uremia, which causes now anemia, which causes nausea and poor intake or vomiting, or either it's caused by the fluid overload. So if you have the fluid overload, you have ascites, so you have a difficulty in breathing, so you have severe hypertension, the child cannot eat well. So there's now reduced the calorie intake. Also, there is inflammatory mediators like interleukin 1, interleukin 6, and nutrition factors. Those one associated with uremia and uremia angiotensin and those hormone systems. Also, there is the risk of infection, the chronic infection, especially for the children with the CKD grade 5 under dialysis. So usually catheter-related infection is more common. Also can be caused by the mineral bone disorder. So also they have a lower level of the insulin-like growth factors. They have a metabolic acidosis and uremia, and have fluid and electrolyte disturbance, inadequate dialysis, which you see having now the fluid overload, and medication like corticosteroid for some children who had some condition like lupus, which require to have a lower dose of steroid. So for inadequate dialysis, what I can say, so we are lucky to get an HIF, which I help the children for dialysis, but it's not still enough because 2 sessions of dialysis per week is not enough because the children are not working well. So note the management of the growth. So you have now adequate nutrition is a pillar in treatment of the chronic kidney disease. So we support to have now the nutritionist review for advice in the counseling. We support to avoid now the reduced phosphate intake so that you cannot pass on complications. You have lower potassium intake. So usually the green, most of the food you have higher potassium. Lower salt in the food restriction so that you can minimize the fluid overload and optimization for dialysis. And also for the children who their epiphyses are not closed, we can give erythropoietin. No, you can give human growth hormone. Sorry. So you give vaccination, especially for pneumococcal vaccine, to reduce now the risk of infections. At least now a little information about now the chronic metabolic acidosis and the chronic kidney disease. So for the chronic metabolic acidosis, it's affected the body and the whole system in these ways. It's having now generation of the celebration of the Bonne disease. That's one we saw. It causes now immense production of the alpha microglobulin, where you have the other complications. It reduces now albumin synthesis, so you have now hyperalbuminemia. You have now also the edema. Increase now muscle wasting, which remain now cachectic. You have acceleration of the progression of the kidney disease, that one we saw in the previous slide. Also, it has impaired the glucose tolerance because of insulin growth factor like 1, and also the growth tradition. So the tactic now for the treatment for the metabolic acidosis, chronic metabolic acidosis, is to have at least bicarbonate at 22 millimole per liter. So usually we give oral sodium bicarbonate. So in the last scenario is to prepare now for renal replacement therapy. This one, it is huge chapters, the big scenarios. That one just is a headline. So we have so many modalities for renal replacement therapy, but the main one are the 3. We have peritoneal dialysis, we have hemodialysis, and kidney transplantations. So usually, before you take now the child to hemodialysis or peritoneal dialysis, you're supposed now to have the counseling with the family to prepare them mentally and psychologically So you suppose now to tell them the modality for the dialysis, which one they will choose, how the cost of it, what is the distance, what they can afford. So we have also to consider how the mental health for the patient. If the patient has a problem with psychiatrist, you can't do peritoneal dialysis. You can do now hemodialysis. Also, if now the family has enough money and the child is transplantable, it's better to do periamperic transplantations, where you can do transplantations without now the dialysis. So you consider how the parent and the children will do now adherence on medications and how they come for the clinic and they come now for the unit for the dialysis. As I said, it's a multidisciplinary team. You need to have now the nutritionist, you need to have the surgeon, you need to have the anesthetist, you have to have the pediatrician. It is just a whole team. So now, what is now our take-home message today? The chronic kidney disease is a complex disorder with several management challenges, especially in small children. Because one, reducing food intake, access, difficult to get now the dialysis, they need to grow. There's so many complications. So CKD requires multidisciplinary team, that one I said, and we need to have the team. Fortunately, in Kenyatta, we have the teams. CKD is an independent risk factor of cardiovascular disease, premature mortality, and the morbidity, and decrease the quality of life. You can now understand, for example, a child is supposed to have 2 sessions of dialysis, and if that child is in the school, you can see now the burden, psychologically how the child is affected, how the family are affected. So it's challenging. So, however, having the extra suspicion and the earlier treatment offer the best outcome in some conditions. And the transplantation is only the successful management of chronic kidney disease. Thank you so much.
Thank you very much, Dr. Syria, for that elaborate presentation. Indeed, we've gone. This is a full lecture on management of CKD in children, where we've gone through various topics and various modalities, and it has been really comprehensive. We really thank you for that. For our participants, thank you for staying with us. We can some of your questions and comments. If you have any questions and comments, you can still put it up in the chat. We still have some minutes before the end of the session. At this juncture, I'd love to welcome Professor Wasuna. I don't know if you'd like to give us a comment on this whole topic called chronic kidney disease in children. You'll see if you're having it on board at a moment. One of the questions Dr. Sirius has been asked here is about the modalities of treatment. But I think you've covered that just in your last slides, but maybe you can just make a comment on it in regards to the role of the kidney transplant and dialysis and where it comes in. Just a mention.
I think, okay, so my slide is on. Now for the modality for the dialysis, so there's so many criteria we consider before you do now dialysis. One is the age of the patient, is now the experience for the nephrologist, is now the location of the parent, the child, and the affordability for the one for the modalities. So when you consider age, for example, is the risk factors in the, for example, in Kenyatta, our machine we have for the children cannot dialyze a child who has weight less than 25 kilos. So maybe rarely for 20 kilos, because there's what called the dialysis blood flow, and the dialysis flow rate, the blood flow. So for the blood flow, if there's a formula we use which is 2 to 8 mils per kilo of the child. So for example, a child who has 10 kilos, even if you use now the high flux dialysis of 8, that we have now 8 per minute. Then the blood flow rate, the dialysis flow rate is times 2 what you have. That is 160. So our machine in Kenyatta cannot dialyze any dialysis flow rate, which is less than 150. So is now less than now those weight. You can't do any hemodialysis. However, at the more hospital, they can even dialysis now also even for the neonate. So which we don't have in our setting. So if now the child is here in Kenyatta and he has chronic kidney disease, which require dialysis, so there is an indication of dialysis. So is the child who is what we assess first. We can assess what called the residual kidney function test, which is we found now how much the urine the child can make per day. So that's the one. Secondary, so we assess now the fluid status. If the child has no fluid overload and the child can make a urine and there's no other complications, you can just withhold until maybe the eGFR is between 10 and 5. So now if the child has fluid overload, has severe hyperkalemia, has severe hypertension, which is not uncontrolled by antihypertensive drug, those one and you're unable to do hemodialysis, you consider to do peritoneal dialysis. Another scenario is now for the transplantations. So as for today, we transplanted a few children. There's 5 we transplanted in 2015, and there's one we transplanted last year in March. So those one we transplanted in 2015, the 4 are still alive. One died because of the loss to follow-up. He never attended the clinic, but 4 still alive. The one we transplanted the last year is the child who had 12 years that times. The child is well, has gained the weight, gained his normal activities, and is doing well. So the transplant have been done here in Kenyatta. So don't be surprised. One of the issues for the children to do transplantations is to have now the donor. The donor is a problem. The second one is now economic barriers. So why the donor is a problem for the children? So look, for example, a child who has 12 years old or 8 years old and is the firstborn. So now in that families, who's supposed to be a donor for the kidney is either the mother or the father. You see, you have only 2 options. So now maybe you may find the mother has another problem like hypertension. That's the risk of exclusions. Maybe the that's another risk of exclusion. So now to convince now the aunt and the uncle to deliver the kidneys, it's not very easy. But if, for example, let's say assuming myself today, I have chronic kidney disease. Now you see, also the society will consider now importance of the man in the families. So I will have now the kidney from my families, both my parent, my brother, my sisters, my wife, and the family of the wife. You see, as long as you are the adult, better you can have the donors, including, for example, even your children. If, for example, now one of the parents at 65 years has chronic kidney disease which requires transplantation, her firstborn who has 40 years, who has 3 or 4 children can donate the kidneys. So the issue with the kidneys, the donation in the children is still a really big problem. So we are trying to push in the parliament if they can now have the clause for the cadaveric transplantations. Once we achieve now that clause, we'll be able to do now so many transplantations in the children. And what I can assuring you, and the other nephrologists can tell you, the transplantation in the children is more successful than transplantation in adults. So there is one who said, can chronic kidney disease treat totally or just stabilize situation within the process of medications? So there is no any treatment of the chronic kidney disease apart stabilization and to delay the progressions. Only the treatment of choice is renal transplantations. So another question is, could you share the blood pressure range if in children? So you can just send me your phone number and send me your email. Then I will give you the book which contain now those the parameters of the blood pressures. So kindly share the slide via your email. Just send me your names. I give you my emails. I think for my presentation, there's no email for mine. So there's the other question from Lydia on someone who asked, thank you for presentation. How common and successful are the pediatric kidney transplantation in Kenya? So pediatric transplantation are not so many as I said. Me, what I know, we transplanted 6 children in Kenyatta. Also, there is other transplantation in at Mpesha in the Aga Khan. So at least for the one we did at Kenyatta, among 6 children, 5 are alive. As I said, the one died because they lost of the follow-up. So we still have the hope, and this is very successful. So there is none. Can future president consider providing learning using clinical scenarios? They speak a lot more addition to the theoretical knowledge. I thank you. So that one, it's okay to do the clinical scenario, but the clinical scenario, it's understandable for the nephrologist and the student in nephrology. So this presentation is focusing for all the group. If I bring now the clinical scenario, which will be okay for the learning, but you see now what will happen for the patient, the nurse who did, for example, surgeries. That one will be difficult because once you start calculating those KI, those figures, it's not very easy. Then also the times. So I think maybe what we can do is just to have, for example, now one scenario, we can have what we call the clinical presentation. That one we can do, maybe what we call the case report. So case report we can do, you can present one successful stories, on the one failing story, then you see, for example, how we can improve. So it's a good idea. That's the message I consider. Next time I will do now, I can share the successful story or failing stories. So do you have to be life treatment to prevent transplantation and rejections? Yes, of course. For the presentation of for the children with the chronic kidney disease, even for the adults for chronic kidneys who have been transplanted, they have supposed to be on immunosuppressor drug forever. However, for the first six months to 1 year, the drug are so many. So the drug are so many, but later alone, as long as now the child is getting better or adult transplant is getting better, we reduce the dose, especially with mycophenolate mofetil. It reduces also the prednisolone. But within the first 6 months, we give now the isoniazid prophylactic. We are giving now prophylactic for tuberculosis. We give also the nystatin for prophylaxis of the fungal infections. So those one you have higher drug dose, but the patient transplanted remain on drug forever. So this one is the request, how safe profloxacin is safe in kidney disease. So there is no any drug which is safer for the kidney disease. And so what you consider, always consider the EGFR. So once now EGFR, it's reduced, there's what's called the renal adjusted drug dose. So usually we have a table where you can see, for example, at which drug you can use, which drug you cannot use, and most of the drugs are still usable for EGFR above 30%. Most of the drugs are usable. Even 15% you are still using. As long as the drug is given in the normal range of the dose, it's not nephrotoxic. However, you're supposed to consider other comorbidities. If the patient is not passing urine, we reduce now the dose. If the patient has another problems, like liver injury, also reduce the dose. So usually we adjust the dose according to the conditions. So what it is for using cephalosporin a patient with a chronic kidney disease. So the cephalosporin, other drug you can still use in chronic kidney disease. But if now you have the chronic kidney disease stage 5, where you have a GFR at around 15%, so you're supposed to reduce the dose. So in the dose, the one I know in children might be different in the adult. So ciprofloxacin and cephalosporin at the eGFR of 15, we are not reducing the dose, apart if the patient is anuric. But if the patient may pass urine, you may give the normal dose. So, but below 15, the dose will be reduced at 50%. So this one say, for example, is there genetic association with the chronic kidney disease? So with the questions, the answer is simple. There are so many genetic diseases associated with the chronic kidney disease. Those including the gene which associated with the tumor of the kidneys, the gene which associated, for example, with the congenital nephrotic syndromes, like NPH1, NPF1-2, what called the nephrine in the podocin. So also other diseases like error inborn error of metabolism also associated with the chronic kidney disease. So there is another question. When you do recommend the use of renal denervation in chronic kidney disease in children? So that one usually have neurogenic bladder only. Another one, how do you raise the immune system to a child who will take a medication for long part, apart diet based? So that one is difficult because you may need now to consider so many factors. The factors, one is electrolyte and acid and bone mineral disease. So it's not easier to increase now the child in nutritional condition. However, you have now the target. One, the target is not worsening the condition you have. That's the one. The second, the target, you can give a tropoetin, you can give him a recombinant human growth hormone when the exercises are not fused. So those are the targets you can use. So another one, you can now increase now the feeding is the adequate dialysis to remove now the food so that you can create the space for feeding. So what are the cardinal difference between the presentation in children and the dose in the adult? So that one I abstain myself because I'm not a physician. What I will give you is for the children, but in the adult, I don't know because that is not my specialty. So maybe the difference between adult and the children, one is the presentation, the second one is the cause. So in the adult, the most common cause of the chronic kidney disease is diabetic mellitus and hypertension and the glomerular disease. So plus some systemic disease like lupus and the rheumatoid arthritis. So why in the children, the most common cause of the congenital, the common cause of the chronic kidney disease are congenital anomaly of the kidney and urinary tract. So another one is the ask at the transplantation with the child with CKD. So that one depends on the skills. If you are using now the living donor and the deceased donor, if you are using the live donor, especially here, for example, in Kenyatta, so the age is almost around 8 because here you can have now the vascular access for the transplantation and anastomosis. So, but elsewhere there is a time you had the child is a Kenyan who stay in the US. That child was admitted last year at the age of 6 and had transplantation in the US at 4 years. Because, so they use now the cadaveric where you can take now the kidney of the younger child and they transplant for the for the children. So now, what is association with immunosuppressant with diabetic and hypertension out of the patient developing on use? So most of the cause of the hypertension is steroid. So that one is in steroid and the calcineurin inhibitors, either tacrolimus or cyclosporine. So it's rare. It's come for the apart maybe diabetes. It's rare. It's transient. Usually, it's curable once you give the drug, and once you reduce the drug, it's curable. Apart if the patient has maybe genetic association with the familial disease, even the one child we transplanted last year has diabetic mellitus, has diabetes, hyperglycemia after 3 months, but has been resolved within 3 months for no insulin. So the most common cause of hypertension is the pre-existing conditions, because the steroid and the cyclosporine, they can increase a lot of hypertensions. Thank you so much.
Thank you so much, Dr. Sylvia, for taking us through and for that for those explanations and even just answering some of these questions. For our participants, thank you. We can see, maybe you can just take a few from those who are raising up their hand as you wind up. James Muraya, if you're able to speak up and ask your question. James Murray, you can be able to unmute and ask your question.
Okay, my question was about what the main causative of kidney failure, because most of the patients you are hearing, they have kidney failure.
Repeat again the questions. What is it?
My question was about what the main cause of kidney failure, because you hear most of the patients here these days, you find they have kidney failures, even from those who are in low economic areas.
So, okay, I can tell you, so there are so many causes for the chronic kidney disease. So, one, there's the risk factors. As I said, you can have the child who has a prematurity, lower birth weight, that's increasing the kidney disease because they reduce the number of the nephron at birth. So the children who have, for example, the diabetes at the earlier stage, whatever any stage of the diabetes after 10 years, the patient you have the one of the part of the chronic kidney disease. So there is hypertension. So whatever it is, essential hypertension or secondary hypertension, you can have now the systemic disease, for example, lupus erythematosus. You can have, for example, preeclampsia in the ladies. So, but for the children, the difference between adult and the children, the most common cause is what congenital anomaly of the kidney and the urinary tract. So that's one including, for example, myastic dysplastic dysplasia, myastic kidney disease, posterior valve reflux disease, dysplastic kidney disease, so bladder dystrophy. So those are the common cause of the chronic kidney disease in the children. Another cause for the chronic kidney disease in the children are what called the glomerular disease. So a child who has acute glomerulonephritis, a child who has acute kidney injury secondary to acute gastroenteritis, it is the risk factor to develop chronic kidney disease in later alone. So other cause, as I said, the diabetes, and the other one can be maybe the calcinosis for someone who has the obstruction. That one can have the cause of the chronic kidney disease. However, most of the patients we saw later because they have the underlying conditions and was not diagnosed earlier. Once they come at the end stage renal disease. And sometimes even you are unable to decide or to generate the cause. That's the thing, for example, the patient who has nephrotic syndrome, focal segmental glomerulosclerosis, membranous nephropathy. membranoproliferative nephrotic syndrome. Those are the nephrotic syndrome which appear in the societies. They have been given the steroid, edema is resolving, steroid, then the appearance. At the time now they come to see the nephrologist. Once you do disease, you find the patient has creatinine which is elevated. So there are so many causes according to the age, gender. So for example, maybe advanced age in the adult. So the prostate cancer, benign prostatic hyperplasia. So ovarian cancer, endometrial cancers, those are the most common cause of the chronic kidney disease. So including hypertension and diabetes.
Thank you very much. Indeed, we've been able to cover a number of topics and a number of things in regards to CKD. Maybe we'll just have one more person asking a question before we wind up. Isige, if you can hear us, Thierry Isige, can you be able to unmute and ask your question?
So there's one question I am saying, there's no other remedy for chronic kidney disease other than transplant. So once now the situation of the chronic kidney disease, there's no other remedy. So however, there's some you can delay maybe transplant. Let's say give an example. A child who has posterior valve reflex. If you detect the area and you do, for example, stenting, so you can progress chronic kidney disease maybe at around 15 years or 16 years. So that one you can progress at the time for initiation of the dialysis or the transplant. But however, once a chronic kidney disease, it's there, because just remember definition. It's reversible. It is reversible strictures and anomaly and functional of the kidneys. So which is more than 3 months. Once a kidney disease, chronic kidney disease, there's no any limit apart transplantation. So there is a question, it is in order to be given forcibly when you saw dialysis and what use for gastron in the disease. I don't understand these questions. Maybe you can request your question very nicely. Then you see, as I said, this is introduction for the chronic kidney disease, not including the dialysis, not including peritoneal dialysis. So ask the question or the panel they can understand, because the technical questions, if you are working in the hemodialysis unit, it's not a meaning a nurse who is working in the surgery unit will know that questions. Let's be pragmatic, ask the question which can have impact for all the team. That's how I can answer your questions.
Thank you. I don't know if Isige is ready with his question, or we can wind up now. I think that we've covered most of the topics. Indeed, our participants, thank you for joining in. We've gone through some of the introductions, the definitions, the risk factors, the etiology, the clinical manifestations, and detailed. We've gone into detail even on some of the management of these conditions. And we really want to thank you for keeping for this discussion, Dr. Syria. So now, for those who are asking about the CPD points, you'll get that within 2 weeks through your email. In case of any challenges, you can email us at knhcpd@gmail.com. For the pharmacists, you can email at knh. Let me just get that in a moment. cpdknhpharmacy@gmail.com. And for that one, use your self-reporting icon to make the CPD claim. We'll still find a way of having the nurses on board. For those asking for the presentation, we'll see how to get it, but you can use the YouTube also channel that is projected on our screens, whereby you can be able to get some of those sessions, or even through the website. But also for the presentation, we'll try to get it through the KNH research and email. for now, allow us to come to the end. We'll have our last, Dr. Sudak, you can give us your last comment.
Thank you so much.
Yeah, yes, you can go on ahead. You can give us your last comment as we close.
Okay, so there is one question where I found someone requesting how I can deliver the book with the figures for hypertension in the children. So let's give my phone number so that you can send me your message. I give you the books. My phone number is 07 16 78 23 25. 07 16 78 23 25. So you can send me just your email, then I will send you now the books which has all the figures for the blood pressure. So thank you for these opportunities. Chronic kidney disease is a challenge. So we still have a long journey to help our children to get now the achievement, to get what the expectation in the adult levels. That's why support them, support the families. As I can say, with earlier diagnosis, a better outcome. For those one who can have the voice, for non-voiceless, just help us to get the rule which can support the cadaveric transplantation, because our children are dying and we can do much when we can do transplantation. So thank you for your times. God bless you. Lovely weekend.
Thank you too for having us. Thank you for sharing with us this important knowledge. Thank you, our participants, for staying with us. We've now come to the end of our session for today. Do have a lovely afternoon. Thank you.